Aloha, everyone. We will be starting shortly. Aloha, we will be starting in just a moment. Aloha and welcome to today's webinar, Care and Choices at the End of Life, the Physician's Journey and the Role of Hospice. Today, we will be hearing from physicians about their journey and the role of hospice. This is a continuing education clinical webinar that's provided by Hawaii Pacific Health. And in order to receive credits, I need to read to you the following. In support of improving patient care, this activity has been planned and implemented by Hawaii Pacific Health and Compassion and Choices Hawaii, American Nurses Association, and NASW Hawaii Chapter. Hawaii Pacific Health is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. Hawaii Pacific Health designates this live webinar for a maximum of 1.5 AMA PRA Category 1 credits for physicians. Physicians should only claim credit commensurate with the extent of their participation in the activity. Hawaii Pacific Health designates this live webinar for 1.5 contact hours for nurses. Hawaii Pacific Health is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education. This activity is accredited for 1.5 contact hours for attendance at the entire CE session. As a jointly accredited organization, Hawaii Pacific Health is approved to offer social work continuing education by the Association of Social Work Boards approved continuing education program. Organizations, not individual courses, are approved under this program. State and provincial regulatory boards have the final authority to determine whether an individual course may be accepted for continuing education credit. Hawaii Pacific Health maintains responsibility for this course. Social workers completing this course receive 1.5 continuing education credits. Hawaii Pacific Health is accredited by the American Psychological Association and designates this live activity for 1.5 continuing education credit. Continuing education credits for psychologists are provided through the co-sponsorship of the American Psychological Association Office of Continuing Education in Psychology. Hawaii Pacific Health maintains responsibility for the content of the program. In order to claim CE credit, please note that in order to receive continuing education credits for this offering, you must claim credit commensurate with the extent of your participation in the activity, complete and submit the evaluation survey that will be emailed to you within 1 week of the offering. Speakers cannot claim credit for their own presentations. Your CE certificate will be immediately available to you upon completion of your evaluation. We are very grateful for these sponsorships and for being able to provide these education credits. During this session, you can ask a question at any time. There's a box on your screen where you can click and type a question, and we're going to be copying and pasting all of these questions into a Google Doc that we will be moderating at the end. So we will answer the questions live at the end of the webinar. So please, again, at any time, put your question in the box. If you see your question disappear, don't worry, we didn't lose it. We just copied it because oftentimes we get a lot of similar questions. So we combine them so that all the details of your questions are together. This webinar is being recorded, but don't worry, we can't see you. Afterwards, the recording will be available. I am very excited by our speakers today. We are joined by Dr. Charles Miller. He is an oncologist and internal medicine physician returning to present with us today. Dr. Ryan Spielvogel, he is a family medicine physician at Sutter Health in Sacramento. He's also active in the California Academy for Family Physicians. Jody Shaw, who is a social worker with Kaiser Permanente. Erin Hamilton, who is the area director for Bristol Hospice, and Rachel Ann, who is a social worker with Bristol Hospice. Compassion and Choices improves care, expands options, and empowers everyone to chart their end-of-life journey. We are the oldest nonprofit organization dedicated to empower everyone to chart their end-of-life journey. And now I would love to hear from you. Who is here with us today? We are going to launch a poll so we can see what your backgrounds are. So please take a minute and let us know what your primary role is. Are you a physician, a social worker, a pharmacist, a registered nurse, APRN? What is your background so we know where our audience is coming to us from? So we'll give everyone a little bit longer to fill this out. Go ahead and let us know where you're coming to us from. All right, it looks like almost everybody has voted. We're just waiting for a few more. All right, let's go ahead and show that poll. It looks like the majority of you are either registered nurses or physicians. And we also have some social workers and psychologists with us today. Thank you, everybody. Today's learning objectives: by the end of this program, you should be able to review clinical competencies for participating in medical aid in dying and requirements of the law, examine the unique role and journey of physicians and practitioners in medical aid in dying, articulate and examine the team-based approach to patient-centered care, and articulate and examine the critical interface and role with hospice care in medical aid in dying. So where do we start? Some quick basics of the law. I'm going to hand it over now to Dr. Spielvogel, who can talk to you about different end-of-life options and the basics.
Hello, my name is Ryan Spielvogel. Thank you very much, Sam, for that wonderful introduction. So let's first just talk about what people's end-of-life options are, because this is a common yet difficult conversation that we have to have with our patients. Somebody's coming into the office or they're in the hospital and they're not doing well, and you can see the writing on the wall, but maybe they don't yet or don't know what their options are. So how do you have that conversation, and what really are their options? So first and foremost, it's that person's body, it's that person's life, and so it's their decision. And if they want to pursue life-sustaining treatment, someone always has that option available to them. So that might be continuing to do chemo or what have you, continuing to come to the hospital when they're having an acute issue. Some other people might not choose that, and they might instead, when they get to that point, opt to go on to hospice, which I know you are all very familiar with, or palliative care, which obviously there's overlap there. But there are other options too. Voluntary stopping of eating and drinking, otherwise known as VSED, where a patient, basically it is what it sounds like. It can actually be quite difficult to do, but some patients decide that that's the way they want to go. And then medical aid in dying, which is really what we're going to be focusing on here. Next slide. So medical aid in dying, what is it? It is a medical practice, and some people actually refer to it more as a medical procedure, in which a mentally capable adult with a prognosis of 6 months or less can request of their doctor a prescription for medication that they can self-ingest and peacefully end intolerable terminal suffering. So that's kind of the general definition of medical aid in dying. And next slide. So something that all of the laws, and we're going to get into the specifics of the law in Hawaii and how it's a little different than some of the laws, the other laws that authorize medical aid in dying in other states, how it differs, but they all have many of the same facets to them. So in order to be eligible pretty much in any of the jurisdictions where medical aid in dying is legal, you need to have a prognosis of 6 months or less to live. You need to demonstrate mental capacity to make this decision. It needs to be voluntary. No one else can be forcing you or coercing you into this decision. You have to be able to self-administer, and you have to be over the age of 18 and a resident in the state where you are asking for this. And a couple of notable things on here that are not on here, rather, which is determining that somebody is suffering. I always find this interesting when I'm thinking about, from my perspective as the doctor, what my role is and how I determine eligibility. There is nothing in the law that stipulates that the doctor must somehow verify that someone is suffering, because suffering is really in the eye of the beholder. And what suffering means is different for each person. It might be kind of what you're thinking of, which is pain, or somebody's bedridden and they have a lot of discomfort. So there's physical suffering. There's also emotional suffering, and there's also loss of dignity. And there's also anticipatory suffering. So some people who have a lot of foresight seek this out in advance of them having intolerable suffering. Just because somebody's coming into the office and seeing you and they look pretty okay doesn't mean that they're not eligible, just because they don't appear to you to be suffering. Something else that's not on here that I think it's important to note is a determination that the patient is absolutely going to do this, that they're serious about going through with medical aid in dying, because that's not a requirement. I always remind my patients that this remains an option. It's totally up to them. It's voluntary. They can go through the entire process. They can have a prescription waiting for them at the pharmacy and decide never to do it, and that's okay. I have had some doctors express reservations over patients before. Oh, I don't really know if they're eligible because I don't think they're actually going to take it. That's not anywhere in the eligibility. So, your goal as the physician, your duty is to determine first and foremost that they're doing this on their own, that they have mental capacity to make this decision, and that they have the prognosis. And if you've been able to do that, then the patient is eligible. Okay, next slide. So there are 2 oral requests. This is again something that is similar among all the laws in the country, that they have to make 2 oral requests to the person called the attending physician, which is really the person who's going to be prescribing. And those 2 oral requests have to be separated by some amount of time. And this is where it starts to differ among the laws authorizing aid in dying among the different states. So in Hawaii, and Chuck, you correct me if, Dr. Miller, you correct me if I'm wrong, but I think this is actually the longest of the waiting periods among the states. But in Hawaii, there must be 20 days, at least 20 days, separating the 2 oral requests that a patient makes to their prescribing physician. In California, it's 15 days. In California, it's 15 days. In New Mexico, it's 48 hours. In Oregon, it's also 15 days, but they can waive it down. They can waive the waiting period if someone is about to expire and you think they're going to expire during the waiting period. So each state has its own flavor for this one. There's also a consulting physician. So this is a 2-physician process. There has to be another physician involved that essentially acts as a check and balance on the prescribing physician. So their main role is to just double check that that patient is eligible, so that the attending physician isn't kind of going rogue, so to speak. And in Hawaii, there is another requirement, and this is, I believe, unique to the Hawaii law, that the patient must be evaluated by a mental health provider to make sure that they're eligible. In the other states, that's an option. So if it's unclear that the patient has capacity to make this decision in other states, then you can refer to a mental health specialist to help tease that out. But in Hawaii, that is a requirement. And then there's a written request, which is generally a fairly simple, straightforward form that the patient signs to state their intent or their desire. Next slide.
Thank you, Dr. Spielvogel. We'll have Dr. Miller do the next slide. I did want to mention briefly, though, that the reason all these laws are the same is that they are all modeled after Oregon. And Oregon was the first state to adopt a medical aid in dying law, which they've had since the 90s. So this is not a new law. It's been around for well over 20 years. And in all the states, there's never been an incident of coercion or abuse. And Hawaii actually does have the most stringent of all the medical aid in dying laws. And with that, I am excited to have Dr. Miller present the next slide. Dr. Miller.
Okay, thank you, Samantha. Let's talk a little bit about what it is to be a provider of medical aid in dying. We're focusing mostly on Hawaii, but as Dr. Spielvogel said, these laws basically are the same throughout the 11 or 12 jurisdictions now. So I think I almost at the point I'm saying we ought to change the wording in the law and not call the prescribing physician an attending physician, because it becomes very confusing. If you're the attending, taking care of a cancer patient who has cancer, and then somebody's, well, you're the attending patient, the attending physician now for the patient's medical aid in dying. The attending is the prescribing physician, okay? He's the one that basically starts the ball rolling for the patient. Let me just make one other point that has come up in the last, since the beginning of the year. The first oral request does not have to be to the same physician who is going to write the prescription. And the Deputy Attorney General for the state of Hawaii clarified that in writing through the Department of Health, so that the first oral request can be made to the PCP, the patient's oncologist, the patient's neurologist, any doctor. And that is the date that becomes the date to start the 20 days, okay? So if the PCP is asked by their patient, doctor, I want to do medical aid in dying. The requirement of the law says the PCP has to document that in the chart. And that then officially becomes day one of the 20-day waiting period. And then if they refer the patient to me to actually do the prescription, I use that date as number one, as the first day, to calculate out when we'll do the second oral request at day 20. So in doing that, when I am evaluating this patient for medical aid in dying, obviously you go through the records. And as Ryan, as Dr. Spielvogel talked a little bit about, that usually the diagnosis is not an issue. I mean, it's pretty obviously a terminal disease that these patients have. The thing that's more art than science is the prognosis. And I tell patients that very, very upfront. I say, you know, I think in my clinical judgment, I think you will have 6 months or less to live, but I could be wrong. And you could live longer than that, but you could also live shorter than that. And the other issue of this is you've got to document. We've got forms from the Department of Health and as well as Kaiser that I document all of the requirements that are met to fulfill medical aid in dying. So you have to follow, it's a compliance process, just like anything else. And then finally, after the patient goes through all of these other steps, the consulting physician, the mental health provider evaluation, and completes the written form, I will then be able to write the prescription. So let's talk about the other providers. The consulting physician has to be, just like the attending physician, has to be licensed in Hawaii. And basically the consulting physician, their job is to say, they review the chart, they review the patient's record and say, yes, I agree with the attending's assessment that this patient meets the requirements of the law and is eligible for medical aid in dying. And then the psychiatrist, and this mental health evaluation can be done by psychiatrist, psychologist, or a licensed clinical social worker. And their only job is to evaluate the patient's capacity to make an informed medical decision. And this is specifically the medical decision about that, yes, they are competent to, and they understand the consequences of medical aid in dying. So next slide. Next slide, sorry. So okay, this is aimed at physicians. How do you respond to requests for medical aid in dying? There are some physicians who don't want to be involved at all, and that's fine. That's their right, their belief. But if you do want to help your patient with this, be prepared. You have to look at your own personal beliefs about aid in dying. And if you are uncomfortable or you're not sure, then you should consult with another physician. And I put on this slide 3 times, listen, listen, and listen. You've got to listen to the patient. Try to understand why they're doing this. My experience has been these patients know very, very well why they want to choose aid in dying as their end of life choice. But they sometimes, you need to coax it out of them to get them to explain it. And that's part of the attending's job, I believe, is to help understand why these patients are doing this. I've not had a patient yet who has not discussed this with family, and next of kin have been very, very supportive in every patient that we've had. And that last bullet there is something that I feel very strongly about. There is no requirement in our law that says if you do not believe in aid in dying as an option, you don't have to participate. That's true. But there's no requirement that you refer your patient to someone who is willing to do it. And I think that that is a question of moral, for a physician, I think you have a moral obligation to refer that patient if you don't want to participate. Next slide. And we'll take it back to Dr. Spielvogel.
All right. So the death certificate. This is a pretty similar requirement among the different laws, the different versions of medical aid in dying in the U.S. And that's that the death certificate, which is a legal document that helps establish somebody's cause of death, cannot have on it that somebody partook of medical aid in dying as sort of their last act. So these laws make it very clear that the death certificate must be filled out as if their underlying condition is what ultimately killed them. Because again, it is. They're only eligible for medical aid in dying if they have an underlying condition that causes them to be terminal. So the cause of death on someone's death certificate, if they've undertook medical aid in dying, is never suicide or accidental overdose or anything like that. It is their underlying disorder that made them eligible for it. So for instance, if it's terminal CHF, congestive heart failure, that's what goes on the death certificate as their cause of death. And I also feel like this is a good time to mention when I'm discussing with patients, someone will frequently have a family member there, at least for part of the visit. And I like to cover with them also sort of the purpose of this law. It protects me, obviously, from being able to participate in this activity and not be liable for murder. It allows the patient to do this in a way that is evidence-based and that we know is going to work. Because I'm sure that before these laws were around, patients were maybe taking more of their medications, their hospice medications, attempting to do something like this, but that's not a for sure thing. But it also protects the family because there are instances where somebody ending their own lives prematurely can have legal consequences or estate transfer consequences or life insurance consequences. And so these laws also explicitly prohibit life insurance and estate transfer and all those things from being able to take into account that someone used medical aid in dying as their final wish. So it protects the family as well from kind of being exempt from needing to worry about any of them. I always mention this to the families and to the patients because there frequently is something nagging in the back of either the patient's mind or in the family member's mind, but no one wants to say anything about it because they want to be respectful of of their mom or their dad who's doing this. So they're just not going to ask, but they're worrying about it. So I usually make sure to bring this up. Okay, next slide. So as Dr. Miller mentioned, there's no duty to participate. So if somebody is, you can't have a disciplinary action against somebody for either not participating or for participating. So the fact that somebody's doing this or decides not to, they can't be disciplined for that in any of these laws. Okay, next slide. Okay, so this is what I already talked about. And also medical aid in dying does not constitute suicide, mercy killing, or homicide under the law. And this, by the way, comes up when there are, particularly when there are physicians that I'm talking with who are maybe not sure or hadn't really thought about medical aid in dying much, and kind of getting your mind around that as a physician, helping to hasten someone's demise can be a difficult thing to wrap your mind around, and that word suicide frequently bubbles to the top of people's minds. So I like to read this, by the way. So this is the American Psychological Association said this about a decade ago. It is important to remember that the reasoning on which a terminally ill person whose judgments are not impaired by mental disorders bases a decision to end his or her life is fundamentally different from the reasoning a clinically depressed person uses to justify suicide. So this is not suicide. This is a person who is going to die, and you are not changing that. You are not deciding or helping that person decide whether they live or die. These are frequently patients who would rather live, but they don't have that choice. And so what you're doing is you are helping fulfill your oath as a physician to alleviate suffering, is how I frame this. Okay, next slide. Okay, so I think we're going to transition a little bit into sort of our individual journeys to becoming the medical aid in dying providers that we are today. So I was going to start with talking about my initial contact with medical aid in dying. So in California, our version is called the End of Life Option Act, is the name of the law that authorizes aid in dying in California. And it went into effect, I believe, June 9th of 2016. And so somewhere around April or May, I got an email. Everyone in our institution got an email that said, hey, this law is going into effect in a couple of months, so we just want to gauge interest and see what providers are thinking about it and who's interested in participating and who's not. So they blasted this email out to the several thousand physicians in our group across Northern California. And it basically was just a quick survey of, what level are you comfortable with? Sort of the most restrictive being, I'm not comfortable with this at all, to the next step up. If my own personal patient asks for it, I'd be okay being the consultant, I'd be comfortable prescribing, and kind of all the way on the most permissive side of things, I would be comfortable being the prescribing provider for either my patients or for other people's patients if their provider has opted out. And before I received this email, I had literally never thought about medical aid in dying before. And so I took a step back and I thought about it for like a day before I decided to answer. I said, well, this is somebody needing a service, and I would want to be there for that person if they needed this. And sure, I guess if their provider opted out, I wouldn't want to leave the patient high and dry. So I chose the most permissive option, thinking erroneously that, oh, I'm sure tons of other docs in my group are choosing that most permissive option because who wouldn't want to help out their patients in need? And thinking that, maybe half or so of docs would opt out entirely. I come to find out that out of the several thousand doctors that this went out to, I was one of 8 physicians who chose the most permissive option. So June 9th comes around and the law goes into effect, and I instantly get several referrals for this. And I think, oh my gosh, okay, I didn't think this was going to happen, but now it's kind of put up or shut up. I need to figure out my actual feelings about this and see if this is something I'm comfortable with or, what have you. So let's go to the next slide. So it's kind of a happy accident that I'm even involved in this at all because I happen to naively choose that option on that survey. Okay, so my first patient, shortly after the law goes into effect, literally the next week, I see my first patient, and he is an elderly gentleman walking with a cane, and I was just so struck by his determination and his gratitude. He told me that he had been waiting for the law to go into effect so that he could take advantage of it. And he was so happy to be able to find a provider who was willing to help him. And I believe those were his words, willing to help him. It's kind of hard as a doctor to feel like other doctors might not be willing to help the patients. And he was just so certain of what he wanted and why he wanted it. And it was super clear. And I had had reservations before seeing him that, oh my gosh, how am I going to judge someone's capacity when they're asking me for, what I was taught was sort of a fundamental contradiction of medical practice, helping someone end their own lives. Doesn't that automatically mean they don't have capacity? But I'm listening to him and he's outlining this suffering that he's already feeling. And this is suffering that hospice wasn't helping with. Hospice is wonderful, but they can't give someone their dignity back. They can't give someone their functioning back. This is a guy who got joy from very specific activities, and now he was disabled to the point where he couldn't partake in any of them. And his disease process was also one in which he suffered dysgeusia, which before last year was a very rare condition, otherwise known as loss of taste. So basically everything tasted like cardboard to him, which is just horrible. And so he said, there's no joy left in life, and it's only going to get worse from here on out. So, I'm done. And it was very reasonable. And I remember, thinking like, wow, okay, this is interesting. I wasn't expecting to feel this engaged about it. And then I prescribed to him, and I talked with his daughter after everything was said and done. And, she told me that, I'll never forget what she said. She said, it was beautiful. We had a memorial for Dad while he was still alive. And then he took the medication and he went out with the sunset surrounded by friends and family. And I just thought, wow, that's powerful stuff. And it just really hit me that this is, she was so also just, thankful that I was able to help out her dad and that they were able to be with him and that they were able to plan this. And it was just really hit me hard and made me realize just how important work this is, and how powerful it could be for patients to empower them when they were feeling very vulnerable and disempowered. Dying is a really disempowering process. And so this is a really tangible way to give them that power back. And that was my first patient. So let's go to the next slide. So then the early times, the first year or two, I was kind of flying alone, solo initially, and then I was able to convince two of my close colleagues to also do aid in dying. So the referrals were coming in quick because again, there weren't that many providers doing this. But the three of us were able to kind of split up the referrals among each other and consult for each other so that we didn't have to then go find consultants. So the three of us were just, kind of seeing a lot of patients for those first couple of years. And that was a really rapid time of figuring out what worked and what didn't, because we were just kind of initially going off of the requirements of the law, and then the rest of kind of the nitty gritty of how to do this well, we didn't have anyone to turn to ask about. So we just had to figure it out. And I would say one of the main things that we figured out early on was the importance of hospice in this process and the importance of good communication with hospice in this process. Things seem to always go wrong when a patient adamantly refused going on hospice, which still to this day, I can't figure out why someone would adamantly refuse that when they are dying and they're suffering. But some people just really have it in their heads that they don't want hospice. And what I would explain to them is, I'm unfortunately a busy primary care doctor. And so I can't be physically present for ingestions the vast majority of the time. And so hospice is my boots on the ground. And so they are the ones that are there. They're going to be helping you through the process. They can't actually, hold the the bottle to your lips or anything. You have to do that. But they can help talk you through the process. And then once you are peacefully unconscious, heading towards passing, they are the primary support for the family. So when somebody starts being cyanotic or having some myoclonal jerks that are very common, there's, they can be the ones talking to the family and explaining, that things are going okay, and then he's peaceful, et cetera, et cetera, et cetera. So, hospice is incredibly helpful. And I usually, my practice now is that I pre-brief with the hospice team beforehand, make sure that everybody's on board, that we've all introduced ourselves to each other so that I know who the hospice team is, they know who I am, they have my phone number, and they're usually, texting me updates throughout the process, that I know when the patient ingests, I know when they went unconscious, and I know when they passed. Or if the nurse has any questions or concerns, they know that they have me on speed dial, and they can get in contact with me. It's reassuring to the hospice team. It's reassuring to me because I'm not freaking out thinking there's an ingestion today and I don't know what's going on. And it's also very reassuring to the patients to know that everybody's communicating. So that's kind of the number one thing that I learned over the first couple of years to do, make this work. And I'm being reminded that the hospice team can actually hold the glass to somebody's lips, but it has to be a voluntary effort, a volitional action on the part of the patient to actually get the medication into their body. So, sucking through a straw, that's their volitional act. But yes, hospice can actually assist them with supporting the medication if they're having difficulty with their strength. Okay, let's go to the next slide. So over time, as I'm learning kind of what's working, what's not, from either kind of a practice perspective and also from a systems perspective, I kind of go from more of a go-to just provider to a system liaison, and starting talking with more of this kind of system level people of how can we improve this process flow, getting a referral in the system so that providers can more quickly get patients to providers, reviewing institutional policy, because originally the institutional policy was fairly restrictive, and getting some terms changed in that, kind of really codifying hospice's role in this, clarifying with hospice their policies, and then eventually sort of turning more into a physician trainer. So as I was gaining more experience with this, the system would start shoving interested physicians in my direction, either someone who's interested in becoming more of a referral specialist in this, seeing other patients, or just one-offs. So physicians who say, I don't really know how I feel about this, but my patient who I've known for 20 years is asking for it, and I want to be there for them. So can you talk me through the process? And so, kind of transitioning into doing these sort of trainings for physicians who are interested. Next slide. And then eventually moving into residency training. So it hasn't come up yet, but I'm faculty. One of my main hats that I wear is I'm core faculty for the Sutter Family Medicine residency program in Sacramento. And so that's mostly what I do when I'm not doing primary care, is I'm teaching the residents. And so we were initially quite off-put. Dr. Miller brought this up earlier, and I couldn't agree more. The term attending is used in the law, and it's very misleading, because what a doctor considers an attending is different than what the legislature considers an attending. And so they define the attending as the physician that has primary responsibility for the patient's health and well-being, or something like that. I'm probably butchering the words a little bit, but they don't define it as a physician who's completed residency and is board certified in their field, which is what physicians think of as an attending. So at some point, it becomes known to me that residents at some other programs are participating in Aid in Dying. And that was like a light bulb moment for me that, oh my gosh, we should get the residents involved. And something that struck me immediately was just how many of the residents were interested. Because of those of you who don't work with residents, a resident is a doctor who's fresh out of medical school, who's going through their specialty training, who's not board certified. So these tend to be young, eager human beings who really want to learn everything that's out there, as opposed to us fuddy-duds who are out in practice, who are already set in our ways and really don't want to learn anything new. So, in our institution, there's about 1% of all the physicians in our institution who are participating in medical aid and dying, only about 1%. As opposed to in my residency program, or the residency program that I'm faculty for, it's about 90% of our residents participate. And that's because they're young, plastic, eager minds. They want to learn new things. So, this immediately became obvious to me as the future of medical aid and dying. That if this is to become mainstream, we need to really be pushing residency training, because these people then go out and practice, and then they're leaders in their field, and they're doing this in their where they're practicing, and that's huge for patients who are unable to find providers because there are so few. So kind of the past 2 years of my existence has really been residency training, pumping out residents who are comfortable with this, having them fulfill all the roles, being the prescribing physician, going to ingestions, getting comfortable with this, and treating it like every other aspect of medicine, because this is just one more aspect of medicine. And so let's go to the next slide. And I think that might be it for me. Oh, today's world. So now I have an official title. I'm not just a rabble rouser telling the system what works and what doesn't. So I'm now the clinician lead for medical aid and dying in our organization. Things are pretty smooth. I get a referral, and then I sort them to the provider, whether it's a resident or attending, who's most available, and I make sure that they're going to be available in 15 days so that they can most quickly satisfy that waiting period requirement. Reviewing patients ahead of time with residents to make sure that they're appropriate. I still save the really difficult ones for me and the other attendings, so that the 35-year-olds who just have metastatic cancer, those kind of really emotionally gripping ones, usually save for myself to shield the residents a little bit. And then we do annual lectures, case reviews. We review difficult encounters among all of us so that we can all learn from each other's experiences. And that's kind of where we are now. Next slide. And so just briefly, our numbers, somewhere around 150 over the past 5 years, probably honestly closer to 200. About a little over 100 in the last 18 months, many of them managed by the residents and overseen by me and my colleagues. And about a quarter of them died during the waiting period, which is really shocking and sad, and that feels like a failure. So the waiting period is frequently the enemy for the patient. Next slide. So my latest patient, this kind of talks to that last slide. My latest patient was last week, and this was a very unfortunate man who was suffering both end-stage ALS and end-stage congestive heart failure. So he was exceptionally weak, but when he was able to do anything, he was incredibly short of breath. And, I spoke with him and his wife, and I let them know based on what I was seeing, I was 90% sure that he wasn't going to make it through the 15-day waiting period. But I'm going to get the process started for you. I'm going to line up a consultant just in case you do, because he was very sure he wanted to do this. But I let them know that he probably wasn't going to make it, and he didn't. So he died around day 5 of the waiting period. And it's one more person who fell victim to that. So, and with that, I'll pass it back to Dr. Miller.
Thank you, Dr. Spielvogel. We're actually going to
Sam rather.
now. Yeah, it's okay. I do want to highlight, we're going to be talking about that waiting period. There's a significant number of eligible patients who don't survive it, but we'll talk about that a little bit later. Now we get to hear from, next slide, please, Jody Shaw, who's going to talk about the roles and responsibilities of the navigator.
Hi, everybody. Thank you so much for joining us after work. And what I know we've all had really busy days, but we're excited to be here, to share our experiences with all of you. Next slide, please. So for Kaiser, we're called patient coordinators here. So there's 2 of us. So myself and Susan Amina, who's an APRN. And I'm the oncology social worker based in the outpatient oncology clinic here. And so for Kaiser, how it starts is a doctor, Susan and I need to receive a formal referral from one of the patient's doctors. So it's typically the specialist or the primary care physician. And then once we get that, referral, then Susan and I actually can just run with everything, and we'll take the patient and family, through the process, get all the appointments set up. But we do start with the first interaction for us. It's very crucial. And so once we get that referral, we reach out to the patient and family. And for me, a lot of times, they are oncology patients that are right in the clinic already, and they just saw their oncologist, and then they're sent over, to come and meet with me. And that's such an important meeting. And I think, like the doctors have touched on already, we really want to get to know this patient and what's motivating them to seek this and to pursue this, but also, really understanding what's most important to them, what are their fears and worries, so getting to know them as well as their family and support system, and then exploring all of the other options for support. And, definitely we always talk about hospice and encourage it. We want it, for our patients hand in hand with the MAID option. And I think like the doctors were, I think Dr. Spielvogel mentioned that, for those patients that didn't have hospice, it really didn't go as smoothly. And we've seen that as well too. So we do work very closely with the hospices, and we've worked a lot with Bristol. We really appreciate them, and we feel that they are we're all part of the same team to support these patients, and we couldn't do it without them. So for that initial meeting, we go over everything with the patient and family, and but we reassure them that we'll just walk them through it, and we take it step by step. And Susan and I stay in touch with the patient and family, as the time is going along. And let's see, next slide, please. So, for us, we try to really, no matter what the patient's condition, but if they are more advanced, we try to set things up as quickly as possible. But we are usually able to set things up within usually 7 to 10 days, 2 weeks or so. So setting up the appointment with the attending, usually with Dr. Miller, with the consulting physician, which is usually one of our specialists, and then with the mental health provider. For us, we've used, I really want to thank Dr. Brian Goodyear and Dr. Eric Jewell. They have been an integral part of our team. So they've been primarily doing our mental health provider visits for our patients. So we get all the appointments set up and schedule it together with the provider and the patient and family. And of course, we go over the different forms and, walk them through those forms. And, so we're also walking the providers oftentimes, through this too. So of course, not Dr. Miller, but, there's other providers. So at Kaiser, it's been nice. I think there's been more and more providers now that are starting to participate. So Susan and I will, talk to them about, so at Kaiser, they really set up a lot of different templates and other things that the providers can easily use in Health Connect to, help them through this process. And then all of the forms are returned to Susan and myself, and then we send it all together into the Department of Health. Next slide, please. So I think we'll see in the next slide, there is, again, the different templates for the different providers. And oftentimes, the coordinators, we make the referral to hospice as part of our support and process. And I work really closely with Erin all the time. And then once, even after our patients start on hospice, we're following them too. So we usually call them maybe once a week or every other week or so, and staying in touch with the hospice team often as well. Just trying to sense if the patient wants to take the medication, when they're going to do that. And also Dr. Miller he's great, and he offers to be there, as well, if the patient would like. So we want to help coordinate all of those things. Next slide, please. So this is one of our templates. This is the coordinator template. Next slide. This is our FAQ sheet, so you can find it right on our Health Connect homepage. It's our patient FAQ sheet. So this is a great tool because if any staff member gets a query, they can give the patient this FAQ sheet. Next slide, please. And this is our guidebook. So we have a guidebook, and it was modeled after one of the Kaiser Californias. And actually, it has a lot of great information. But what's really the most important thing in this, on the back, the last page, we have a checklist, and it lists all of the different steps. So at Kaiser, some of the other steps is we also work with our patient financial services, and so they'll let the patient know upfront what the cost will be. And our oncology pharmacist will do a teaching also once they get the medication too. So that's another step we have. So those are all listed on the back page so that the patient can see where they are in the timeline and check things off. Next slide, please. So this is some of our data. It's not fully current, but this is going from 2019 up to March of this year. So until that time, we had 108 referrals. Majority, like for most of us, I think, have been cancer. We've actually had, a good number from the neighbor islands as well. There were some that were found to be ineligible because of either prognosis or, they didn't have the mental capacity. 39 prescriptions were written by that point. 35 dispensed, and 61 of those patients have passed, 26 from medical aid in dying medications, and of notice, 16 died within the waiting period, so about 25%. Next slide, please. So when Kaiser started, we're lucky we have the closed system, so they really were able to, plan and develop this prior to the law going into effect. So there are a lot of different areas that got this set up, and some of the things that have changed too. We've seen there's been improved time from referral to dispensing of medication. We've definitely, grown even closer to the hospices and working in partnership with them. Like I mentioned, there's been more doctors of ours that have been participating. and more, choosing to be attending physicians and prescribing. Previously, for the medications, we were partnering with Jake Blackduff, the pharmacist in Kailua. So that was a non-Kaiser pharmacy. But now we are able to dispense the medications at our Kaiser pharmacies. So on Oahu, as well as on the neighbor islands. Previously, our neighbor islands folks had to come over here, but now they can get it on their own island. And then we moved from DDMP2 to DDMA. Quest, also our Medicaid patients, it's a benefit, so we have a special workflow for that. But I think always it's still been a challenge to get the referrals in a timely manner. And it's always, I think we're always working on education of our providers and staff so that we make sure we get those, early on in the process. Next slide, please.
Thank you so much, Jody. I just want to really emphasize how incredibly important the role of the nurse is in places where nurses don't do patient navigators. A patient can easily fall through the cracks. And so we're so grateful for Jody, the team at Kaiser, and all the nurse navigators who help patients at end of life. And now I'm excited. I know we're starting to get short on time, but I'm excited to hear from our friends at Bristol Hospice. Next slide, please. So Erin and Rachel Ann, I hand it over to you.
Hello, thank you so much. Hard to follow everyone right before, but just want to also say thank you so much for the partnership. We have learned so much from everyone and still have more to learn as we go along. So hopefully we can share a few pearls with you. So for the hospice support, of course, we're going to be receiving the patient. And not only are we going to be getting patients that are on hospice, but they may be palliative patients, as mentioned before. So that's going to vary in what their wants of treatments are going to be. So some we may have on supportive care. So they might still actively be pursuing chemo or radiation when we're looking outside of network, like with HMSA patients. So it is a little bit of a different type of a patient population. And when we receive the referrals, of course, we're going to be doing all of the normal things that we would be doing for any other patient, which would be the DME, the hospice related prescriptions, and providing care wherever the patient is located. And I think that is probably one of the bigger challenges that we have been facing recently, because as we can see with the structure of the folks that presented today, when we receive a patient and they have been through the HPH or the Kaiser system, there's a lot more structure in place already. So for the home and the facility, whether it is at a foster home or care home, there are some individual challenges with that. Our first case profile was a gentleman who was about 67 years old, pancreatic cancer, very, very supportive family. At that point, when we were starting in preparations for Our Care, Our Choice, we really wanted to focus and have a specialized team. So we had a specific MD, a specific registered nurse, a nurse practitioner, CNA, social worker. And then what we soon changed and how we evolved from that was our first patient was actually on us with hospice for quite a while. And then decided and was kind of pursuing Our Care, Our Choice. And then we found out in the middle of it. And then the team, of course, organically got attached to the patient, and the patient got attached to the team and family as well. And so what we really learned from that takeaway was that, yes, having a specialized team is important, but again, asking those questions of how do we adjust with the environment? Because what we've come to see and notice is that we're having a lot more patients that are requesting it, and they may be coming in from perhaps a system where they don't have a PCP in the community. They have maybe never had this discussion with their physician in the community. And that does present some other challenges as well. So I think that's something that we can definitely touch on. So we kind of talked a little bit about what we first thought about having that high focus specialized team and those obstacles. And next slide. And then our case profile too, I am going to go ahead and let our social worker kind of describe that, Rachel Ann Taliloa, and some of the dynamics of that as well.
So we had a patient, I will call her Thelma, and she was 64 years old. She was a female who had a primary diagnosis of liver cirrhosis, alcoholic cirrhosis of the liver. And she had a comorbidity of esophageal cancer. And she came to me in last year, February. And she came on services for her because she was in and out of the hospital at Queens. So she was not a HPH patient, nor was she a Kaiser patient. If we had Jody on board, I'm sure I wouldn't have anything to present on. But she was with her son and in and out of the hospital, and APS got involved because she didn't have enough care. So APS was able to place her in a foster care home where she had difficulties getting along. And so she was moved to another care home in my area. And that's how I got her. And she had a peg tube, and she insisted eating by mouth. And she wanted to continue to do that, but it was causing her to vomit pretty violently. And through February and March, we were working on a lot of her issues staying at the care home with her finances and with the caregiver. And I remember going through these social issues and her sitting me down and looking me in the eye, and she said, "Okay, but once we get this arranged, will you help me die?" And that's kind of how our work with medical aid and dying began, because prior to that, there was no talk of it. And so I educated her a little bit about her options, but we were so focused on her social issues at the time that it didn't really come up again until those were resolved. And so in the beginning of March, at the end of March, early April, she became very insistent and she was asking all of us. And so we would call a lot of interdisciplinary team meetings with the doctor, all of the team members, and also her case manager and her care home operator. And she faced a lot of difficulties navigating the requirements. And they broke down into her emotional roadblocks as well as the systematic ones. She had no navigator. She had no cell phone. So all of her communication had to go through the caregiver. She had her case managers on board who act as a third party to regulate the relationship between the person in the care home and the care home operator. And the case management agency did not want to participate because she had opted for this. So there was that. They also wanted to inform the family, which the patient had decided she did not want to tell them. So they were not educated about the system either. And that presented to be a difficult roadblock for her. The patient was having conflict with the caregiver. And now the caregiver was saying she didn't want to keep her in the home to allow her to perform this. So there were a lot of issues that started to arise as she was wanting to do this, and it was unclear, her motivation. But I felt strongly, and so did my team, that we weren't there to question her motivations unless she wanted to talk about it. And so we provided her emotional support through that. She was insistent at the beginning of April. In mid-April, I called Jody, and Jody connected me with Sam. And Sam was able to get us prescribing physicians as well as a consulting physician. And because she didn't want to tell her family, we had volunteers who were able to sign her paperwork. It ended up being at the end of April that she was almost to the end of her waiting period, and she was still very insistent. And she told me that, I get better and I feel good, and I think maybe I don't want to do this. And she says, and then I eat, and then I throw up. And I realized that this is going to be the process forever, and I'm done doing this. So she had her mindset, and she ended up deciding to tell her family, which opened up another can of worms. And all in all, it was a lot of moving pieces trying to act as a navigator in a system where we were restricted on how much we could help or what our role was, as we have policies that sometimes limit us from performing certain functions, in which this case, she had no one else to do those things. So we learned a lot from this, and she ended up going through with it. And because she told her family, and even though they weren't on board at first, they came around and they were by her side. It was a very long process when she ingested the medication, but it ended up being a better experience than any one of us could have hoped for.
Thank you. So as we definitely can see, we had to evolve the situation because we started to get a lot more patients from different, whether it be hospitals or from the community. And then the main questions were, how do we normalize this? You know, if we were looking at any other hospice patient, would we be specifically having a specialized high focus team, and how can we present that education to all of our staff? And then some of the other side effects, definitely, like as Rachel Ann was saying, was really just that navigating. So whether there was financial restrictions, if they're a Medicaid patient and they're in a foster home and the foster home isn't agreeable, or the case management agency isn't in support of it, we did have some issues with that as well. And then the witnesses, just the legal documentation and just trying to navigate that. I definitely want to say Compassionate Choices can help, you know, whether it is a hospice or it's the community members, at least with that education piece. So they've been very helpful on that. Next slide. And so as we kind of talked about the different challenges, whether they are not coming from the Kaiser or HPH system. So I think one piece that we can really work on together as a community is updating the PCPs out in the community who maybe are not educated or specifically had those examples or patients to be able to interact with, and having them be a part of this as well. And then looking at the different locations of where a person may choose to want to do this. And then the pharmacy training, that was also one of the challenges. We do have Jake as well, and that's helpful. And depending on the participation of the PCP, that can also be something that can be helpful and serve as a solution for that. And then of course, working with community partners. So we would be doing, you know, having our home setting patients and be addressing it as we normally would with any other hospice patient. So again, if we do not have the patient navigator in place and they're not coming from the Kaiser or HPH system, we're going to definitely be having that conversation about mortuary, pulse, advanced healthcare directive. The pre and post bereavement is a huge piece of it as well, especially if the family members or the caregivers need that support. And then as we talked about the challenges for the location of the patient, and whether that be Medicaid, finances, and then is there a transfer needed? Because in the second example that we had, we were in a place where the foster home was saying that it wasn't going to be something that they would be able to support. So looking at if it was Medicaid, did the patient have to use their personal finances, and would we be transferring to another care home? Would we be transferring into an inpatient facility? And the different challenges, and really just having the communication and the conversations with the caregivers. And then of course, there is the additional challenge that we all know about, which is going to be, of course, the limitation of the facilities that are going to be in support of this. And then as we've kind of navigated this as well, we're noticing that patients are very specific. So they have a special date and a special time, and that's all part of this piece as well. So making sure that we are really working on the family dynamics, the caregiver and the social worker and chaplain are a huge, huge piece of this as well. I would say that's probably one of the largest aspects of time and involvement and education. And then as Rachel Ann was saying, where we have our patients where maybe they don't have access to a cell phone or they have limited resources, getting them that physical paperwork, bringing in the phone to them, having those conversations with their family member, and really just making sure that we're all on the same page. And then, of course, we have the additional pieces of, again, the education with the case management agencies. I think that's another place where we can improve on, because they are involved with the care. Many of them may not have had exposure to, what does this law look like? What are the different challenges, and what are the HIPAA rights that the patient has as a choice of their own? So definitely things we can work on. And then as we, of course, changed, we definitely went from, having that hyper-focused team to more, how can we have our entire company know how to really take these patients on? And then how can we better support our staff regarding the dynamics of every single case, and making sure that we have a debrief. So that was a huge part of it. Yes, the pre-planning of, whether it's the location, the staff, the time, the meds, everything. But I think a large piece of it is really the staff and and of course the family and caregivers, bereavement, but really having our staff debrief and making sure that if there is any needs for them as well. So we have an implementation in place if they want to take a day off, the rest of the day or the next day, or if they want to have a group debrief, we are going to be doing that. And then where can we learn? What did we learn from this experience? How can we improve? And then also if they'd like to have a private debrief, whether that is internally or having an external support system with a psychiatrist or psychologist, we're also implementing that as well. And next slide.
Thank you so much. Thank you for sharing your experience. And I want to remind everyone, you can ask a question at any time in the Q&A box, and we will be getting to them shortly. Right now, Compassionate Choices, we are very hands-on in Hawaii, and we are very hopeful that by doing things like this clinical webinar that you are all attending today, that we will not be necessary soon. That is our goal. We want to normalize this practice because right now it's almost a question of privilege. If a patient is at Kaiser or Hawaii Pacific Health, maybe at Queens, they can hopefully access the law, but then there's other patients who, unless they know to come to us, they may not be able to access the law. And that is not the intention of the law. No one should have to, we should not need to get involved in order for a patient to be able to access the law. And so our goal really is to have more medical providers who feel comfortable supporting their patients, and have more hospices that have doctors who can act as both the attending or consulting physician, as well as nurses and social workers who can be there to support the patient. And that's how it works in other states, but it takes time. And now in Hawaii, we have 2.5 years under our belt. And so we're hopeful that we'll be there soon. Can you go to the next slide, please? Next slide. So, as we said earlier, Hawaii has the most stringent of all the medical aid in dying laws. And again, these laws have been around since the 90s, which may not feel that long ago to some of us, but actually was. And, in places like New Mexico and other states, nurse practitioners and physician assistants can actually act as the prescribing or consulting provider now in New Mexico. I was really hopeful Hawaii would be the first state to do it. We tried so hard, but unfortunately, even though nurse practitioners already have it within their scope of practice in Hawaii to do everything that an attending or consulting physician does, they are not able to support patients in medical aid in dying. And this is a huge problem, especially on neighbor islands. If you live on East Hawaii Island, it is incredibly difficult, if not impossible, to access the Our Care, Our Choice Act. And again, this is, it shouldn't be a question of privilege. If you don't live in Honolulu, you can't access the law. That is not how this should work. And the Department of Health actually has supported a bill over the last 2 years at the Hawaii State Legislature that would allow nurse practitioners to act as both the prescribing or consulting provider as well as give the prescribing physician or nurse practitioner the ability to waive that mandatory minimum waiting period of 20 days if the patient's unlikely to survive it. We found this waiting period really to just be an incredible time of suffering. There's no other purpose for it. A patient still has there has to see 2 different providers to ensure that they're terminally ill, 6 months less to live, all the rest that you've heard today. And so, if you're interested in getting involved, we really are hoping to bring this bill back next session. It's passed out of lots of committees. There's a huge amount of support from the people of Hawaii. And so we just need to encourage our legislators in Hawaii to make this a priority bill. In fact, in California, there's a similar bill that is halfway through California's legislature. Other states that have authorized are trying to do the same thing, because if a person is dying and they want this option, they need to be able to access it. And so you can go to the next slide. We're really hopeful that this bill that continues to be supported by the Department of Health passes. So again, we're happy to do clinical education. I hope that you share this webinar with other medical providers, spread the word. Like Dr. Spielvogel, he was able to talk to his friends, et cetera. And, it took years, but they were able to put together a really good system so that patients don't fall through the cracks and they can access this law if they are eligible. Next slide, please. We have a lot of great free resources on our website. I'm not going to take a long time to talk about it because you can go through it yourself. But if you go to compassionandchoices.org or /Hawaii, it's a Hawaii specific page. And we have a plethora of free resources. You can contact us anytime. All of our work in Hawaii is led by our amazing, incredible consultants who are on the ground there. Next slide. I think it's time for questions. Yes, time for questions. All right, we have about 8 minutes left, so we will get to as many as we can. The first question is for Dr. Miller. Dr. Miller, you talked a lot about how important it is to document the first oral request, and I'm curious, why is it so important to document the first oral request?
Well, because that starts the clock ticking on that 20-day waiting period. And earlier, the first year, there was some confusion about if a patient had talked to his PCP about death with dignity, aid and dying, and they still had to come to me before we could start the clock ticking on that 20-day period. So the Attorney General has said, as long as the request is documented in the patient's medical record, that starts the clock ticking. So, and I've got a patient actually right now that I am working with. He requested from me on the telephone, said, Dr. Miller, I want medical aid in dying. And this was on the 28th of May. And we went through all of the process, and I documented that. And so his day 20 is coming up on the 18th. And I will be writing his prescription on the 18th. So that's why it's important.
Thank you, Dr. Miller. And so I hope everybody understands that it's, 20 days may not sound like a long time, but to a person who's dying, it's a tremendously long amount of time. And, we hear from patients, even if they survive that 20 days, that it's 20 days of fear and anxiety, worried about whether or not they're going to lose capacity to be able to access the law. And nobody should have to spend their final days in this way. Next question. I believe Dr. Spielvogel answered this in the chat box, but for those of you on your phone, I think I'll ask the question, but the question is, have you worked with any hospice organizations which do not participate with medical aid in dying? In other words, they will not be present in the room with the patient during the ingestion.
Yeah, so there are some hospices in my area who not participating for one reason or another, specifically a Catholic affiliated hospice in our area. Originally was not participating at all. So if their patient said that they wanted to do this, we basically had to figure out how to transfer them to a different hospice. But I've actually had a couple of patients in the last month with them where now they are saying that they're fine with it and they'll support the patients through medical aid in dying, and just their medical directors can't act as consultant or have those roles, which other medical directors at other hospices are usually willing to act as consultant, but then the nursing staff and the social workers can still do what they need to do.
Thank you, Dr. Spielvogel. And I'll reiterate, under the law, anyone can be in the room with the patient if they want. If the patient doesn't want anyone in the room, they have that right. Although we always encourage patients to have someone with them. And as Dr. Spielvogel mentioned earlier, if they do end up drinking the medication, someone can actually mix the medication. They can hold the cup up for the patient, but the patient themselves need to be able to ingest it. So maybe they suck it through a straw. If they have a feeding tube, someone else can put the medication in their feeding tube, but they need to be the one to ingest it through the plunger. So this is important to know under the law. Now, healthcare systems and hospices may have their own policies on top of what the law provides, but that is what is allowed.
So, Samantha,
yes, go
just
ahead.
one more comment on that whole thing. Besides the PEG tubes, medical aid in dying medications can also be administered per rectum, and it's just as effective and works just as well.
Thank you, Dr. Miller. We have a few minutes left. Next question, has there been any abuse or coercion since the Our Care, Our Choice Act went into place? Were there any patients who were pushed into using it?
Absolutely not. I mean, I think people, that you have to understand, this process is very, very regulated. And when we meet these patients, it's actually very obvious. It's they who want this. Nobody is making them do this. And if anything, it's almost the opposite, that we have to say, like our two patients, we have to say, I'm sorry, but your mother just doesn't have the mental capacity to meet the requirements of the law. And those are the sad things that happen. No, there's been no evidence and no occurrence of any sort of coercion or abuse.
Thank you, Dr. Miller. And as the policy wonk, I'll add, there hasn't been any coercion or abuse in any of the 10 states or Washington, D.C. that have similar laws. We have 2 minutes left, so I'd like to give everybody an opportunity for last thoughts, maybe why this is important to you or anything that, I know we just skipped some slides, if there was something burning that you wanted to share with everyone. So final thoughts, just popcorn style, whoever wants to go first.
Yeah. The only thing, and I kind of brought this up in my initial discussion. I totally understand, and it's very, very appropriate that no physician can be, if they don't want to participate, they do not have to participate. But I look at this, and that's fine, and that's their judgment. But I look at this as then, okay, I understand that. But I feel, and Ryan, you can talk about this a little bit, I feel strongly that a physician has a moral responsibility to care for his patient and care for him and relieve the suffering. Anyway, Ryan, any comments?
Oh yeah, no, I just wholeheartedly agree. the only other thing that I feel like comes close in my practice is delivering babies. Oddly enough, just in terms of just sort of the how meaningful an experience this is for the parties involved, and that you get to be there to help a patient, like really help them. When I'm managing someone's diabetes and their hypertension, I know I'm helping them, but like this is the most fundamental way that I can help relieve somebody's suffering. And it's a special thing to be a part of for your patients, and to be there for them I feel like there's nothing more that comes. Well, there's a few things that come close, but it is the epitome of being the physician for your patient, being there for them in their time of need.
Well, thank you everyone so much for being part of this webinar. We're over time. Thank you for joining us, and we hope to do some more clinical webinars and talk to you in the future. Take care. Aloha, everyone. Mahalo. Thanks, everyone.